I am Dr. Manish Shah, Site Principal Investigator for the Charlotte, Houston, and Milwaukee Pre-Hospital Research Node of the Pediatric Emergency Care Applied Research Network, also known as PCARN, and I have some exciting updates about recent research on pediatric pre-hospital seizures in the PCARN network. Funding for several of the projects with which I was involved and will be discussed in this presentation are noted here. By the end of this module, people will be able to identify areas in which EMS could improve the management of pediatric seizures, summarize the major challenges that paramedics face in treating pediatric seizures, and update one's pediatric seizure protocol based on existing evidence. Seizures are one of the most common medical reasons why emergency medical services are requested for a child and account for 12% of all pediatric EMS transports based on EMS data from PCARN. When seizures are not stopped quickly, they can lead to neurologic morbidity, respiratory compromise, and even death. Timely delivery of the right dose of a benzodiazepine using an ideal route is essential to effectively and safely treat pediatric seizures in the pre-hospital setting. In 2014, the EMSC program collaborated with the National Highway Traffic Safety Administration to publish an evidence-based seizure guideline. Shown here is a summary of the main recommendations based on the evidence at that time. These recommendations have subsequently been integrated into protocols around the country, and they've also been integrated into the National Association of State EMS Officials Model Clinical EMS Guidelines. Since this was published, there have been several studies that have demonstrated that hypoglycemia occurs very rarely, 0.5 to 2% of the time in the actively seizing child. So if I were to rewrite this guideline for 2020, I would recommend that checking blood glucose not be first priority, but be second priority. For the recommendation about route of administration, intramuscular, intranasal, and buccal benzodiazepines have been compared to intravenous route and have been shown to be at least equally efficacious, whereas this is not the case for rectal. Due to the time required in obtaining either intravenous or intraosseous access in children, the evidence-based guideline recommends not obtaining intravenous or intraosseous access initially. Despite having published guidelines, the relative infrequency of pediatric EMS cases compared to adults contributes to variability in managing pediatric emergencies. Also, just because a protocol is changed does not necessarily mean that practice will change. Integrating many of the evidence-based guidelines recommendations into protocols in Charlotte, Houston, and Milwaukee, we compared specific process measures before and after the protocol changed. In 533 actively seizing children across these three sites, we found several improvements, including a 27% absolute increase in the use of the preferred intramuscular and intranasal routes after changing the protocol. Also, there was a 10% absolute increase in the administration of midazolam to actively seizing children. However, there was room for improvement since nearly half of the patients still received the wrong dose of midazolam based on what the protocol at the time stated was the correct dose. We also found no change in several other outcomes, such that seizure activity upon emergency department arrival was fairly common, occurring in 1/3 of patients before and after protocol change. One of the likely reasons why patients are still seizing on ED arrival is that many of them are being underdosed. Dosing errors occurred in half of the patients, and 75% of these patients were underdosed. Another reason why seizures may not be stopping prior to ED arrival is that there are delays in midazolam administration, such that the average time to benzodiazepine administration after arrival to the scene is 14 minutes. Human factors related to the ease of medication dosing may also play a role in this variability in practice. With conventional dosing, paramedics must first determine a patient's weight, often with a length-based tape, and then perform several calculations to determine the dose of medication to deliver to the patient. Since multiple steps are required, this adds to the cognitive load on the paramedic, thus increasing the risk of a calculation error. In addition, opportunities for error are also introduced due to both the lack of standardization of the route by which the medication is given and the variable dosing depending on the route. This results in both increased frequency of underdosing of benzodiazepines and delays in medication administration in seizing children. The combination of receiving a low and delayed dose makes it more likely that the seizure will not stop after the medication is given. Seeing the need for improvement in both process and outcomes measures prompted us to conduct a multi-center qualitative study to identify paramedic-reported enablers and barriers to adherence of the seizure protocols in Charlotte, Houston, and Milwaukee. Data from interviews of paramedics who recently cared for an actively seizing child identified many systems issues affecting protocol adherence. Two specific systems level enablers were point of care references that obviated the need for dose calculation and the ability to provide medication by more than one route. Several systems level barriers included the lack of mucosal atomizer devices and intramuscular needles for infants, protocol ambiguity about whether or not focal and febrile seizures should be treated, and protocol ambiguity regarding maximum doses based on route. Paramedics offered solutions to these barriers, which included simplifying dosing among all routes of midazolam, having point-of-care references matched to their protocols that decrease the cognitive load required to calculate medication doses in stressful situations, and addressing the barriers by clarifying the maximum pediatric dose, clarifying which seizures should be treated, and ensuring that equipment is available for all sizes of ages. So the problem with pediatric pre-hospital seizures is that 1/3 of children that were seizing during EMS care are still seizing on emergency department arrival. Half of children get an incorrect dose of midazolam, which is usually underdosed. And having paramedics do math contributes to this problem. So the need is to simplify midazolam dosing so that children get the right dose and stop seizing. So what does this mean for your community? Intramuscular and intranasal midazolam should be the first priority for treating seizures. Hypoglycemia is rare, so glucose checks should be deferred until after the first dose of midazolam is given if the seizure has not stopped. Focal and febrile seizures should be treated the same as generalized and afebrile seizures, and modifying policies and protocols to avoid calculations is necessary.